distension is an absolute requirement for a successful virtual colonoscopy exam. Protocol begins delivering carbon dioxide into the colon at a flow rate of 1 liter per minute. It gradually ramps up to 3 liters per minute until pressure has stabilized. This ramp-up allows the patient to become comfortable with insufflation before the maximum flow rate is reached. We recommend a pressure setting of 20 to 25 millimeters of mercury. Once the desired pressure has been achieved, CO2 flows as required to maintain that pressure. This means that should CO2 be lost due to absorption, leakage around the tip, or reflux into the small bowel, it will be replaced without intervention by the clinician. When the total volume of CO2 reaches 4 liters, and for every 2 liters thereafter, the machine pauses the flow to allow the user to check for small bowel reflux. Pressing the Flow Stop Run button will reinitiate flow. Front panel controls. Before we begin the insufflation demonstration, let's take a moment to review the front panel controls. The power switch, shown here, controls the power to the machine. Simply flip the switch on or off. Here we see the gas supply indicator. 3 different colored LEDs indicate the relative amount of gas available in the CO2 cylinder. As the gas in the cylinder is depleted, fewer bars on the indicator will illuminate. You should change the gas cylinder when only 1 orange bar remains. When only the red bars are illuminated, an alarm will sound. It is not possible to start the flow until the gas cylinder is replaced. Next, we have the volume liters display. This display indicates the total amount of CO2 used for the procedure. The volume reset button, shown here, is used to clear the volume display to 0 and signal the start of a new procedure. Resetting the volume will also restart the flow rate ramp-up sequence. The Flow Stop Run button controls the flow of CO2 into the colon. As you can see, pressing this button once starts the process. Notice that the button is illuminated when gas is flowing. The initial flow rate is 1 liter per minute. This will gradually increase to 3 liters per minute. If at any time you need to pause the flow of gas, simply press the Flow Stop Run button again. Remember, as a safety feature, once the total volume of CO2 reaches 4 liters, and for every 2 liters thereafter, the machine pauses to allow the user to check for small bowel reflux. Simply press the Flow Stop Run button again to reinitiate the flow. The pressure adjust dial shows the pressure set point, which is adjustable between 0 to 25 millimeters of mercury. We recommend a pressure setting of 20 to 25 millimeters of mercury. The pressure adjust display shows distal pressure. It is not possible to set the insufflator to a pressure higher than 25 millimeters of mercury. Occasionally, however, you may observe that the distal pressure rises above 25 millimeters of mercury. This can be due to a colonic spasm during the patient breath hold for the CT scan, or as a result of patient movement during repositioning from supine to prone. No intervention is required. As a safety precaution, if the distal pressure exceeds 50 millimeters of mercury for longer than 5 seconds, an alarm will sound and the display will flash. The system will automatically vent to 50 millimeters of mercury. The alarm will stop without any need to reset once the pressure drops to 50 millimeters of mercury or less. The gas output connection to patient is a connector for the patient tubing set. Insufflation demonstration. Procedure setup. For added convenience and safety, a quick reference guide is supplied. The front gives brief insufflation instructions, while the back provides some troubleshooting information. The guide can be physically attached to the protocol unit for easy access. First, open the CO2 tank by using the wrench provided on the back of the cart and turning the tank valve 1 turn to the left or counterclockwise. To maximize gas cylinder life, it is important to keep the tank closed when not in use. Next, turn the insufflator on by the power switch. Now set the desired pressure. We recommend an insufflation pressure of 20 to 25 millimeters of mercury. Prepare an administration set for use and place the fluid collection bag in the holder on the cart. Do not connect the administration set to the insufflator at this point. Connecting the patient. The administration set is used to deliver CO2 from the insufflator to the patient. At the distal end of the tubing is a tip for patient placement. We offer 2 different administration sets to better serve your needs. EZM catalog number 6470 is our protocol administration set, which includes a latex-free 20 French catheter with 30 cc retention cuff for single-use insufflation. EZM catalog number 6450, shown here, is our protocol administration set with latex-free flexi-cuff retention tip, including a 100 cc retention cuff for single-use insufflation. Next in line is the fluid collection bag, which captures any residual fluid left in the colon, removing it from the path of the gas flow. The fluid collection bag fits into a holder on the cart. As an added safety feature, a 0.1 micron hydrophobic filter located at the connector helps protect the insufflator from contamination by any fluid that might get past the fluid collection bag. Finally, the connector to the insufflator is on the proximal end. To connect the administration set to the insufflator, simply push the connector into the output connector on the insufflator. To disconnect, simply press down on the top of the output connector and remove the administration set connector. When the patient arrives, he or she should be placed in the lateral decubitus position. The tip should be placed in the patient's rectum before the administration set is connected to the insufflator. Use caution when inserting the tip into the patient's rectum. The tip should be inserted until the proximal end or base of the retention cuff is just beyond the anorectal junction. In most patients, the blue line on the 20 French tip should be approximately at the location of the anal verge. The cuff may or may not be inflated, depending on practitioner preference and sphincter tone of the patient. If it is determined that cuff inflation is necessary, fill the syringe with 30 cc's of air, attach the syringe tip to the yellow side port on the catheter, and inflate the cuff by discharging the air out of the syringe. Disconnect the empty syringe. After inflation, the base of the cuff should be at level of the sphincter for best retention and maximum safety. If necessary, the cuff should be gently pulled back until its proximal end rests on the anal sphincter. Any fluid that enters the tubing from the patient should be guided into the fluid collection bag. Once the fluid has drained, the administration set connector should be inserted into the port on the front panel of the insufflator. Supine insufflation. For the purposes of this demonstration, we will be using an artificial colon. We have modified the administration set, EZM catalog number 6470. Instead of having a tip, it has a 3-liter bag attached, which approximates the size of an average colon. We are now ready to begin supine insufflation. Press the Flow Stop Run button to start the flow of CO2. Once the flow of CO2 is started, the colon will begin to distend. Remember, the flow rate starts at 1 liter per minute and gradually increases to 3 liters per minute until the colon is fully distended. You should now roll the patient into the supine position. Some users roll the patient during insufflation to distribute the gas. Generally, the colon is fully distended when all of the following are true. First, the pressure adjust display varies by no more than plus or minus 2 millimeters of mercury from the set point. And second, the volume liters display is reading at least 2 liters, and it is either increasing slowly or not at all. In most cases, you will find that 2 to 3 liters of CO2 will be all that's needed to fill the colon for the supine scan. In some cases, however, you may find that more CO2 may be used. Some reasons for this may be patients with larger colons or patients with incompetent ileocecal valves who may experience reflux into the small bowel, or leakage at the point of entry of the tip, particularly when the cuff is not inflated. Remember, as a safety precaution, when the total volume of CO2 reaches 4 liters and every 2 liters thereafter, the flow will pause to allow the user to check for small bowel reflux. Pressing the Flow Stop Run button will reinitiate flow. Once you determine that the colon is distended, you should take the SCOUT scan. If distension appears adequate, take the CT scan. If distension is insufficient, try rolling the patient, such as is done in barium enema, to further distribute the gas. Prone insufflation. Once the supine scan is complete, roll the patient into the prone position. It is not necessary to make any adjustments to the system. Some sites use positioning blocks, towels, or pillows to raise the sternum and sometimes the pelvis in large patients. Wait for the pressure to stabilize at the set point. Now you are ready to take the SCOUT scan. If the distension is adequate, then take the CT scan. After the scans are complete. Once you have finished the prone scan, you will want to provide the patient immediate relief from the distension pressure. If it's illuminated, press the Flow Stop Run button to discontinue the flow of CO2 and disconnect the administration set from the front panel of the insufflator. If the enema tip cuff was inflated, deflate it at this time. Gently remove the tip, close the slide clamp, and discard. Always make sure that the CO2 tank is closed when not in use. Otherwise, the tank may leak CO2 and empty prematurely. To close the tank, use the wrench provided on the back of the cart. Simply tighten the valve by turning it to the right or in the clockwise direction as demonstrated here. Troubleshooting. Occasionally, a patient may report discomfort at the beginning of insufflation. This can be managed by pausing the flow of CO2 for several moments or temporarily lowering the set point pressure. When the patient is comfortable, the flow should be returned to the desired set point. In patients with a tortuous bowel or an occluding lesion, it may be more difficult to achieve distension of the entire length of the colon. If the pressure stabilizes when the volume is less than 2 liters, this indicates a likely incomplete distension. In this case, roll the patient using barium enema technique. If the insufflation appears inadequate on the SCOUT scan, check the administration set for kinks, closed clamps, or blockages in the flow of CO2. If the problem occurs in the prone scan, try to elevate the patient's sternum and pelvis with positioning blocks. This will help the abdominal cavity distend more freely. Check to make sure that the insufflator has not paused. If it has, restart the flow by pressing the Flow Stop Run button. If during initial insufflation the total CO2 volume exceeds 4 liters, or if the pressure does not stabilize, small bowel reflux may be present. If you suspect small bowel reflux, take a SCOUT scan to confirm. If reflux is evident and distension is acceptable in the SCOUT scan, proceed with the study. If distension is insufficient in the SCOUT scan, additional CO2 may be required under the supervision of a physician. Press the Flow Stop Run button to restart the flow of CO2.